So, wow, what a presentation, what innovation. I hope you're going to take some questions. So, questions? Come to the microphone so we can hear you. People on the web can hear you, please. Please go ahead.
So thanks, thanks, Dan. So I'm Jeremy Nobel. I came here because of two activities I have. One on the faculty at Harvard Med School and the Public Health School on public population health and so on. You covered that really well. But the other is working as medical director for the Northeast Business Group on Health, which is a regional business coalition representing mostly self-insured employers, IBM, GE, Verizon, but also the city of New York. And I just think this is really one of the most tremendous overviews at both a conceptual level but a practical level on population health. So I just wanted to commend you.
That's a big compliment. Thank you.
But, so I went to the business group to start something called the Solution Center. And clearly, the problems you talk about need solutions. And we look for solutions that meet three criteria: effectiveness, generalizability, and scalability. Because if you think about the business community, and that's really the focus of today, it's not one size fits all. Our members, include very large companies, some of whom will be speaking later today. But they're very small employers and business, and it scales down to people running small printing shops or fast food places and so on, as healthy as they may make them. They're still small employers. From a practical perspective, how do we move from inspiration? Because the ideas you've presented, I am confident will get the attention of our members. They already have.
Yeah.
But how do you move forward? And in your last slide, thank you for kind of some general comments. They're still kind of at the treetop level. How do we move from inspiration to execution? And I'm wondering if there are any concrete, almost playbook kind of suggestions. So as we have the convenings, and they go on around the country in regional business coalitions, we can actually move people from the vision that you so nicely articulate to some very practical things they can do.
Thanks for that question. Well, maybe I'll go back over to here. So, at the end of the day, I think the CFO often makes the decision whether or not you're going to do something like this. And I think going back to this demonstration, I think if you try to do everybody, you're going to fail right away. I think just like communities, you want to find those employers who are most committed, who are willing to maybe take some budget from the human resources and some budget from marketing, some budget from their foundation, and orchestrate that perfect storm. The C-level executives need to be engaged, first of all. And they need to stand up and say, we're doing this and we have enough money to do it. And you have to do enough initiatives, I think, within that, that people feel like, wow, something really significant. It's not just, a lot of these companies just put that sort of window dressing on. I think for businesses, there's a big opportunity. According to this Gallup data on workplaces, the number one determinant of whether or not an employee likes his or her job is, do they have a best friend at work? And I think there's an enormous opportunity, playbook-wise, to connect people strategically so that their relationship transcends the commercial or business relationships. It might go at home, probably doesn't get into their personal business. But setting up those networks internally, going through and auditing and find the 200 little tweaks to the policy and the built environment inside the building and a committee to do things outside the building. Measure it rigorously. Do it the employer who really wants to do it big. And then from that, once you showed it work, you can distill down into a more scalable model for other companies. But again, starting with the companies that are most ready and most committed.
Hi, I'm Paula Lance. I'm a member of the Round Table. I grew up not too far from Albert Lea, Minnesota.
Oh my
actually.
God, that's
and I'm
clean living there.
I'm a demographer, and I'm one of those public health people you were talking about who is really interested both in my teaching of students and in the intervention and policy work I do, focusing on at-risk communities, because I'm someone who focuses a lot on disparities, socioeconomic disparities in health and racial and ethnic disparities in health. Enjoyed your presentation very much, and it's very thought-provoking. The point where you said you're starting with communities who are ready, that makes me worry a little bit, because I think, in essence, if the at-risk communities are the ones that aren't ready, and they probably are not going to be as ready as Albert Lea and some of the places in Iowa you talked about, I'm worried that's going to even exacerbate some of the disparities we're seeing already. So do you have any advice for those of us who really do want to keep working with at-risk communities that aren't ready, and how to help move that forward?
Just a clarification, Albert Lee, 15% of the population there is Hispanic migrant workers. They're very poor. So rather than say communities, I should say cities. So we try to intervene at the whole city level. And okay, we're not necessarily working in the poorest neighborhoods, but the policy we work, if you're denormalizing tobacco, if you're making healthy foods more accessible and cheaper, if you are making it possible for people to walk, that often actually benefits poor people more, or public transportation easier. That's benefiting those at-risk communities. So I will tell you, I made up my mind early on that if you try to be good at everything, you're going to fail. So we have this little bucket. We do try to go citywide, but we also know positively impacts, but not necessarily focuses the at-risk.
Good morning. I'm George Flores. I'm a member of the Roundtable. I'm also an employee of the California Endowment. We also are deeply dedicated to the prospect of addressing not only population health, but equity in communities. And I think some of the concepts that you put forward about readiness, yes, has to do with equity. In fact, maybe scratching this a little bit more, the question really is how do we address readiness? Is that perhaps where we should be looking to create more readiness in communities so that they're more prepared to change? We call it people power, and it's investing in the people themselves, and it really does take working directly with communities, even those that are the most disadvantaged, so that they themselves can take on some sense of self-determination, capacity, and resilience. These are very important traits in order to be ready to enact the change. And they have to do it on their own behalf. Having an organization swoop in and doing it for a community doesn't seem to work nearly as well. There's not the sustainability and ownership and appreciation. You can build a park, but will they come? It becomes a paradigm that we see. So I think looking at readiness from the perspective is what can business do to help communities become ready is something that we ought to put on the table.
It's a good point, and I should have been clear. We don't necessarily assess individual readiness, as you're talking about, but more leadership readiness. Do the private and public sector, are they open to innovation, or we want to preserve freedoms and we want to preserve the status quo? And that, in communities like that, I'll say don't waste your time or money with me. But you'd be surprised how many American communities where leadership, A, works well together, and B, wants to do something like this. And if you have all the main components, leadership components signed on, you can be pretty sure that that's reflecting of a larger population. So, but to your point, yeah, individual readiness is a Gordian knot.
Good morning. Judy Monroe, member of the Roundtable and at CDC. I was recently at Healthways and heard about how popular these purpose workshops are.
Yeah.
And so I was intrigued this morning when you said that then you do the speed dating and have them connect with volunteer organizations or so forth. So my question is that sustainable? I mean, once they go through the workshop, and then if it is sustainable, what kind of impact is that having on the communities if you have more volunteers with these organizations?
So I'll just kind of give you my spiel on that. And you'd be shocked how many middle Americans wake up in the morning tired, make breakfast for their kids, march off to a job they don't like. Most Americans don't like their job. They come home tired, they make dinner, and they watch 4.4 hours of TV every day. That's an American average. For all of a sudden, somebody in health to stop and say, this takes 3 hours actually. And there's a guy named Richard Leiter. I think he's the best in the country. He's AARP's guy too. To sit down and take them through an internal inventory to what do I like? What are my passions? What am I good at? What do I like to do? And where's an outlet? And when it comes to philanthropy stimulates the same neural pathways as sugar and crack cocaine. In other words, if you give people a little taste of it, You don't get everybody, but you get kind of a tipping point of people who will keep doing it. So the idea is we newly have these people aware of this is what I like to do. It's not what I do at work necessarily, usually isn't, but this is what I like to do. And then we give the Humane Society, the Battered Women's Shelter, the Salvation Army, they got 90 seconds. 90 seconds, this is what we do, this is what we need, the table's over there. And so then we kind of encourage, okay, give them an outlet for that purpose so it has some lasting power. And the other secret here is you want to make sure you curate a volunteer experience for people. If you tell people, go volunteer, and they have a crappy experience, they're gone. But if you have a special experience for them where they're given some instruction on how to do it, and maybe there's a leader, then you get a much higher rate of long-term engagement. Thank you for your question.
I'm Mary Pittman, and I'm a member of the Roundtable and president of the Public Health Institute in California. Very interesting presentation. Thank you very much.
Thank you.
One of the things that struck me as I was listening to your original Blue Zones was the sense of homogeneity and a sense of common culture. And I'm wondering whether you're seeing that as an important factor and whether you're seeing something different with diversity. And maybe you're seeing that in Kauai and the beach cities. But most of the others seem like, a pretty similar population.
Yeah, it certainly is easier if it's a homogeneous population. Now, Los Angeles was anything but homogeneous. In fact, about 45% of the population there was either Asian or Hispanic. And for Fort Worth, say huge Hispanic. But it was very easy. In homogeneous populations, there's a lot more civic pride to harness than in hugely diverse communities. There's a common language often, but our approach, we don't pretend there's a silver bullet. We've developed what we call silver buckshot. So we have 120 little interventions, evidence-based, that we know work. And so before we even start, we'll ask ourselves, is this a place where there's a lot of civic pride? Is there homogeneity? Then we can pull from the civic pride bucket. But if there's no civic pride and people really don't have a common language, then you got to start pulling from a different bucket. So we're not depending on it, but you're right, it does make it easier.
Maybe there's some new strategies we can brainstorm, since our reality is that the world is becoming much more diverse, and homogeneous communities are probably going to be less the majority in the future.
Yes, you're absolutely right.
Yeah.
Thank you.
Hi, my name is Melissa Wong, and I'm an intern with the Clinton Health Matters Initiative at the Clinton Foundation, and I'm actually currently working on a project for Blue Zones. It's like literally on my desk right now.
Really?
Since I have been working on it, I've had the fortune to
What's the Blue Zone project?
We're working on a potential proposal for partnership between the Community Health Transformation Project at the Clinton Health Matters Initiative and Blue Zones.
Oh, sweet.
Yeah.
Nobody ever tells me anything.
So I was wondering, you spoke a lot about the kind of health metrics that you have measured through your programs, but I was wondering if, when communities, restaurants, schools undergo the certification process, are there any metrics by which you measure their adherence to the specific criteria within those programs?
Yeah, so this is where, it starts costing money. So in every one of these cities, we basically know how many restaurants there are. For example, in the beach cities, there are 556 restaurants. So we hire enough staff that they can go to every one of those restaurants that'll let them in and take them through our Blue Zone pledge. And they have to achieve they don't have to do everything, they have to do 70 or 80%. And then we come back a second time and make sure they've done it. And if they've done it, then they get the certification. Now, the type of questions we ask are, have sales in healthy foods gone up, or soda pop sales go down? They often don't like to hear that, but we do. And so, we can't get how it impacts their customers' health, but we can get sales figures.
Hi, Dave Kindig from the Roundtable and University of Wisconsin. Thank you very much.
Oh, same prairie as Minnesota. Good.
There you go.
You like cheese?
Yes. So I've heard a lot about blue zones, but this is more. I really appreciate this update. So
You want it?
we just this roundtable just came off a very intense 2-day workshop, our previous one, about the role of education in health, and sort of this actually almost overwhelming relationship between years of schooling and quality of schooling and some of the outcomes that you're talking about. And of course, that's connected to employment and some of those other social determinants of health. I was, when you put up your life radius, and you said we have the individual, but then we moved to the policy, I was kind of thinking, okay, he's going to put high school graduation rates and economic development policies and early childhood stuff in there. Yeah, but it isn't there. So, and I wonder why that is. And I have a feeling it connects to the other questions you got here about readiness, that perhaps some of the places like Albert Lee, I don't know that, and I don't know the international places are more educated and better employment rates and whatever. So, what's your thinking about that as a policy environment?
Yeah, no, stay there. I'd actually like to ask you a question. So, I'm gonna blend theory with reality now. So typically we have enough budget to hire, in a city of 100,000, we can hire maybe 8 people. And we do have the ear of city council to change. So if you wanted to increase the graduation rate with policy or with a very small staff in the city for 3 years, and you had all this other stuff too, how would you apportion those resources? What would you do?
Well, I don't have a cookie-cut answer for that, but that's a lot of what the work of our roundtable is struggling with. But in the lower performing communities and the less advantaged communities, those are the issues that have to be put forward, and they're as important as the exercise and diet issues, because many of those are socially constructed. But I appreciate your question. Perhaps this roundtable should have a more precise answer to it, but I think it is part of your life radius needs to be a part of your life radius framework.
Yeah, I totally agree. And to the extent that our approach with schools, same way with grocery stores, is we sit down, and actually the Clinton Initiative has a very similar program where you essentially take schools through a checklist of the best practice policies, best practice programs, and we try to get them to adopt. I don't know if that impacts their graduation rate, but it certainly impacts the experience they have at school and whether or not they grow up well.
This one, the last question.
Thanks. Mark Goravich from the Department of Population Health at the School of Medicine at NYU. Great and stimulating presentation. My question has to do with small versus large cities. So much of what you described was with small cities, and you, at the very end, you showed the Fort Worth as an example, where I guess your work is just beginning. Do you have, given the sort of community focus of the work that you described, do you see issues unique to large cities, and how do you see tackling them? I'm thinking, of course, also of the city we're in.
Yeah, so Fort Worth is 775,000 people.
Right.
So right away we had to start with the bigger budget. We've hired 20 people. But the strategy of making sure Mayor Betsy Price, who was in the New York Times this weekend, she was on board, Chamber of Commerce, the Boeing, I understand somebody from Boeing, they're on board. So we made sure we had the leaders on. So we have a vector for changing citywide policy. We have the same ability at access to city government. But we just worked the plan. We need 5 people to hit all the restaurants. We need 4 people to hit all the schools. We have 4 people hitting all the top employers. So it's the same strategy. It's just more people to execute it, but it's the same plan. And stick around. We have baseline measurements. We're going to be in there for at least 5 years. So maybe next time I see it, one of these roundtables, I'll have a more thorough answer. Thanks for the question.
I've got a closing question for you. So very, very energetic, very innovative thinking, very stimulating. very challenging, some of the concepts that we've had. So, and I know you've been working from community, city by city up, but what lessons would you have for national policy in terms of improving health of the nation as a whole that might come from your work so far?
Well, so I think I really believe that all government starts at the local level. So I think you have to demonstrate. We're finding this now as we go from cities to states. So we're starting to impact state government, mainly in Iowa and Hawaii. You have to show local successes. So I think we all would agree that Americans should eat less junk food and drink less soda pop and move more. But a lot of these programs cost money, and federal government is probably resistant. So if you can prove it at the local level and provide that case of other Americans actually have done this, I think you have a much, as you know, the American food policy is a Pandora's box. So I try not to jump into that morass.
Thank you. Maybe we will. I am sure you will agree with me that this has been very stimulating, just really an important way for us to start this conversation with business about improving health. And so thank you so much, Dan, for that. With that, I'd like to invite the first panel to come to the table, or come to the stage. That's Andy Weber and his panel. We're going to be, this first panel will be moderated by Andy, obviously. He's the Chief Executive Officer of the Maine Health Management Coalition, a member of the Roundtable, and a member of the Workshop Planning Committee. And Andy is just a terrific guy in many, many ways, and it's always a pleasure to have him on the stage and leading. Thanks, Andy.
Thank you, George.